Assalamu alaikum. It's really a great pleasure and honor to be at my alma mater. Some 54 years after the graduation from King Edward, I thought I will share some of the thoughts regarding cerebrovascular malformations, which has been topic of my interest. Rather than showing you a lot of pictures, there will be few, but mostly what I have gathered and learned through the years dealing with vascular malformations. I have no conflict of interest. We have an AVM database that is managed through my John R. Davis Chair Fund, which is an endowment fund. So, since most of the decisions of the treatment of AVMs is based on natural history, it is very critical to understand its influence on these malformations. First of all, it is the bleeding throughout lifetime which is the most critical risk. There are other conditions, people get symptoms, seizures, neurologic deficit, headaches. They are not life-threatening, but bleeding definitely is. In the 1960s, it was felt that as we grow older, maybe getting to about age 60, the incidence of bleeding would decrease. That is not true. In our own experience, the highest period of bleeding presentation is under the age of 20 and over the age of 60. In between, you have more other symptoms like seizures and so forth. The most significant studies, as you can see the references, one was from Mayo Clinic and the other one from Helsinki, showed that the risk of bleeding is about 2 to 3% per year. Robert Spessler's group came up with the idea that small AVMs bleed more commonly than the large ones. The small AVMs are more common, so we see them more often. But actually the large AVMs also bleed, and this is shown by Laakso from Helsinki. And I mention Helsinki because their education and treatment system is such that most patients are treated at one central hospital. So their follow-up is tremendous. And so they found out that out of 63 patients, 37% experienced hemorrhage with an annual rate of 3.3%, which is the same. These are the large giant AVMs. Why interest in neurosurgery, in AVM surgery? As a resident, I trained at Henry Ford after getting to US. And Henry Ford is like Mayo Clinic and Cleveland Clinic, so all of the patients are actually followed and seen in the institution and treated. So we have a very good follow-up. I was seeing patients as a resident who were coming in with multiple hemorrhages, and when you talk to them about surgical treatment, they will say, so-and-so told me never have anybody touch the AVM. and people would have multiple hemorrhages and die. While we were spending tremendous resources treating conditions that we were not curing, the AVMs were curable. So I thought that it would be really service to the patients to get it treated. So what are the therapeutic issues? These relate to the location of the malformation, the involvement of functional areas, accessibility to the AVM, availability of resources, ruptured versus non-ruptured, symptomatic versus asymptomatic, like incidental, risk of treatment versus natural history. In ruptured AVMs, I have used the management principles. First, establish the diagnosis through CTA and obviously ultimately with an angiogram. Address hematoma urgently and not the AVM. If the hematoma is small, no active intervention. If it is large and life-threatening, carefully decompress, approaching through a cardiectomy, avoiding the AVM. Now, that's not always possible, but in most cases it is. Treat the AVM electively 4 to 6 weeks later, depending upon the size of the hematoma, degree of mass effect, and neurologic status. In comparison to the aneurysm, the risk of rebleeding from AVMs only increases twofold. That's about 6% in the first year. So the risk is very low. I have had one patient bleed at 6 weeks, but they don't have rebleeding that frequently. The vasospasm is extremely rare unless the bleeding was from an aneurysm. If feasible, treat the intranidal or prenidal aneurysms through endovascular approach. Repeat the angiogram prior to definitive treatment because the hematoma might have split the AVM. The AVM may not be completely visualized initially due to the mass effect, and occasionally very small AVMs spontaneously resolve. They thrombose, but in that case, it is important to repeat the angiogram several weeks later because actually it might still be there. The treatment modalities obviously are observation, symptomatic treatment, which is not preventing hemorrhage, that's management of seizures, embolization, which is rarely definitive, mostly as an adjunct, microsurgery, radiosurgery, and multimodality treatment. And despite all the advances, we still have challenges, especially dealing with very small AVMs, deep AVMs, giant AVMs, AVMs in the elderly, and incidentally found AVMs, because you always have to look at the risk of your treatment versus the natural history. In the small AVMs located, they are microsurgically removable unless they are in thalamus or brainstem. They are medically unsuitable for surgery, severe neurological deficit from hemorrhage, failed other treatment modalities, and the patient against surgical intervention. Obviously, it's ultimately the patient's decision. Radiosurgery is best suited for AVMs that are less than 10 cc in volume. Best results, occlusion in 85 to 90%, but more commonly, it's only about 60 to 70%. There is a latent period of 2 to 3 years with persistent risk of bleeding that always needs to be considered. AVM located in deep and critical areas are most suitable for radiosurgery. If you take a very small AVM, targeting the AVM is a definite concern, and follow-up MRIs and angiograms are needed. Take this small hematoma. We generally would pass it along, and he had no other risk factors, and astutely the people decided to do the first angiogram, looked okay, but we repeated the angiogram, and he had a small Sylvian type AVM. It's very easy to remove it. However, it's also easy to treat it radiosurgically, and that's what he chose. Here's a patient who presented with seizures at another institution. Again, surgically removable AVM, but was elected to treat it with radiosurgery. A year later, developed edema. And if you look at the middle MRI and the left one, edema is higher than where the AVM is, and you have an area of necrosis. We repeated the angiogram. The AVM was exactly the same like it was, and surgically took it out, and that's the post-operative angiogram. Embolization, it has evolved over the years. Lozanoff started with silastic spheres to float it into the circulation and hoping that that would carry the spheres into the feeding vessels. Proximal feeding vessel occlusion was not effective. PVA particles mixed with ethanol and suture material was used. And now Onyx is the most effective and easy to use, but it's quite costly. It's really successful as a standard alone treatment. Now, most people, when they select it out, would report about 10 to 12% success rate. That is not sufficient. It's very useful as an adjunct. The best possibility of its help is occluding the feeding vessels from the deeper location, which is obviously difficult. You need to consider added risk for the whole treatment. I feel very strongly that the neurosurgeon be available on site for managing complications, preferably around the angio suite, to participate in decision making as to which vessels to occlude, and have to avoid getting the embolic material into the veins. Again, essentially, grade 1 and grade 2 spatular malformations are treatable microsurgically. It is immediate and best result, and multiple large seizures our own include in this. Mortality is less than 1%, significant morbidity is less than 5%, and cure rate is 100%. Back in early 80s, one area that was of concern was basal ganglia, the deep AVMs. Our experience was that most of these actually can be surgically treated, and we reported that. Here is a young fellow, about 18 years old. This is an old EMI scan. This hemorrhage occurred in the left putamen area with interventricular hemorrhage. He was treated with proton beam therapy. This was his AVM. And 3 years later, the AVM looked exactly the same. And therefore, we took him to surgery and took it out. He had mild dysphagia for about a month and then recovered. Here is a young lady who again had a hemorrhage. This we were able to approach pterionally. This is her malformation, and this is her post-operative angiogram without neurologic issues. So we reported on different techniques, different approaches. Majority of them are amenable to microsurgery. Radiosurgery definitely a choice. Need to approach through safer corridors. The feeders usually too small for endovascular occlusion, and embolization, if possible, is very helpful. Here is one posteriorly located. Here is one in this splenium and parasplenial area. Treated it through this 3/4 prone position with the operated side down, coming from the side of the tentorium. We reported this back in 89, 90. This is very helpful. It gives you access to the medial side of the hemispheres and even the top of the cerebellum, so you could get the feeders right away. We have used some preoperative assistance like using MSI and then intraoperatively doing phase reversal studies, which would tell you the sensory cortex. Parasylvian AVMs are again considered to be difficult because of the small feeders and involving the vessels from the sylvian fissure. Our experience has been quite reasonable. In 12 years between 2000 2012, we treated 15 patients. 8 had radiosurgery, 7 had surgery, and 1 had surgery after radiosurgery. 9 remained the same, 3 worsened, and 2 improved. Here is a patient was having severe headaches. You can look at this AVM. We were able to embolize the feeding from the anterior choroidal. Rest of it was direct surgery. We did functional MRI to see where the speech center was. This was on the left side, and we were able to directly do it with microsurgery. Again, was dysphasic for about 2 or 3 months, but then whole thing resolved. Giant AVMs, over 32 years, we have treated 65 patients, 50% presenting with headaches, 50 with seizures, hemorrhage 41%. 42 patients had surgical resection, 2 had embolization, and radiosurgery. The obliteration rate in surgical cases was 90%. Mortality was 15% in treated ones and 22% in untreated. Here is an 18-year-old who ended up having a seizure after this bleed with mild right hemiparesis. This is his MRI. You can see the location of this AVM. Here is his angiogram. 18 years old. What do you tell him who has already bled? It required a fair amount of counseling for the youngster as well as for the family. We knew he is going to have a deficit. He would have right, maybe hemiplegia, hemiparesis, but untreated, his future was not very bright, and it was too large to treat it with radiosurgery. We did embolization and then took him to surgery. I have a practice of getting an angiogram during the same hospitalization, because if the AVM is not completely removed, take them back to remove it, because we serve no purpose to the patient if there is residual AVM. The risk of bleeding exactly remains the same. So he had a small residual. We took him back a week later and took that out. He was initially hemiplegic, slowly started recovering. In about 2 months, he started using his left arm to use his computer. He has spastic gait. He's functional, has gotten married since then, went back to college. He's functionally employed, and I'm sure he's not happy with his weakness, but he is satisfied with his outcome. Here is another fellow who had seizures, and you can look at his AVM. Look at the location. Again, the choice was, this is again a 21-year-old. Choice was whether he can live with hemianopsia or he's going to live with this AVM. And he chose the hemianopsia. We embolized him with onyx. You can see 2 or 3 sessions, and ultimately resected it. Here is another one, had even a mass effect, very large AVM. So arteriovenous malformations in children, hemorrhage occurs in much higher percentage in children. Children tolerate the effects of hemorrhage as well as the risk of surgery much better, just like head injury. And considering much longer lifetime exposure to AVM in children, I think they should be treated much more aggressively, even at a higher risk, and preferably by microsurgery. Occasionally, very young children have recurrences. I have had one patient where postoperative angiogram was fine, but some years later developed in the same area additional vascular lesion. Vascular malformations and pregnancy. Pregnancy increases the risk of bleeding about 2-fold. Bleeding is most common in the 3rd trimester and postpartum period, hardly ever during delivery. If there is life-threatening hematoma, evacuate the hematoma and treat the malformation electively, follow the patient in high-risk pregnancy and delivery by C-section. In an elderly, they do actually the same way. I don't think the age is really a factor that we should worry about. And here is experience with about 28 patients, and 87% were treated with surgery and they did very well. There are some patients where the feeding vessels are actually occluded, and so you cannot use embolization. There is a report that Dr. Atar Inam actually did, like this one. So you have to treat it directly with surgery. Occasionally, as mentioned, the small AVMs actually spontaneously occlude, but you have to follow them. Technical considerations, detailed selective and superselective angiography, position the patient to maintain proper orientation, craniotomy with wide exposure, visualization of feeding vessels and draining veins, approach feeding vessels early, avoid injury to the draining veins. This is common stuff. And despite all that, we still have some patients that we cannot treat. Our approach is absolutely collaborative, multidisciplinary. Each patient is discussed individually, treat malformation whenever feasible. Microsurgery in our hands is absolutely the preferred treatment. Endovascular support is utilized, radiosurgery is done in selected deep malformation, and obviously the patient is the ultimate decision maker. We have not been able to update because of some issues with our database, but up until 15 we have had some 700-800 patients that have been treated with AVMs. So in conclusion, I've learned a great deal about vascular malformations and still continue to learn more. These vascular lesions require multidisciplinary approach with appropriate team and that works for the best interest of the patient. We still need to learn more about it and to find better ways and safer ways to treat them. Above all, I think to me the most gratifying aspect has been knowing my patients, supporting them, and sharing in their difficulties as well as the thrills of their lives. Thank you very much.